My name's Rodney Crampton. I'm 71 years old. I've had challenge with sleeping probably since my middle years. Didn't bother me too much when was younger and had lots of energy, but probably the last 10 years or so, lack of sleep, don't cope with it quite as well as I used to. I didn't mind it. I actually thought I was coping with it okay. I just didn't feel that, I was sleeping better. I actually, I've known a number of people, other people in my family that have similar sleeping problems, and they've been on the CPAP machine, and after, a few days, a week, they felt they were sleeping quite a bit better, so I had high expectations, but it didn't seem to work for me. My doctor is highly encouraging me to try and find some other answers, and I'm looking for some other answers. So that's kind of where I'm at now.
I'm Alan Froese, age 42. Would consider myself to be fairly active, fairly healthy, really big snorer. My wife encouraged me to do something because she would say that when I would, in the middle of the night, that I would, stop breathing for periods of time, and a heavy snore, which was news to me because generally overall I get really good sleep is what I would consider. Today I haven't, as of the last probably couple months, I haven't been using it because the effects that I guess I would think I would see in terms of, what we're told to me, better sleep, all that stuff, never, even after using it for probably a year straight, as much as I could, I didn't really notice anything.
Good morning. I'm Dr. Amy Bender, backup host for today's segment of Sleep Disruptors, putting the sleep back into sleep medicine. Snoozing all day has the day off. Rodney and Alan's stories are far too common in our field today. The common denominator, sleep. To put it plainly, CPAP did not improve either Alan or Rodney's sleep. The result in Rodney's case, yet another dead end in his search for help. In Alan's, a question as to whether he should have been treated at all. In both cases, a CPAP machine collecting dust wasted healthcare resources and wasted dollars. I know some of you are thinking, we know that AHI is flawed. We know we need a better way to diagnose sleep apnea. For us at Sleep Disruptors, we say, you're asking the wrong question. The real question has to be, how do we help people with obstructive sleep apnea sleep better? My first guest, Dr. Richard Berry, is professor of medicine at the University of Florida and medical director at the University of Florida Health Sleep Center. He is here to help us answer that question. Dr. Berry, the recent Beyond the AHI special article had a great reference to Blumenthal and McGinnis, who stated, if something cannot be measured, it cannot be improved. Can you tell us a little bit about how that statement applies to sleep studies?
PSG records a tremendous amount of information to enable us to stage sleep. However, this tremendous amount of information gives us relatively few results.
Given there is not much information leveraged within the PSG, what is the added value of PSG over home sleep apnea testing for diagnosis of OSA?
If PSG is to survive compared to home sleep apnea testing, we have to add more value to the data we obtain by PSG. In particular, we need to be able to accurately determine differences in sleep quality. We can determine how much the AHI is benefiting. The real question is, how much is sleep quality benefiting?
Tell us about your bird's eye view of the different flight pathways PSGs could take.
On the left, PSG changes like a wise old owl. On the right, PSG remains the same and faces the possibility of extinction.
Think about that. We've been scoring sleep for over 40 years, but we still don't have a reliable method to assess sleep quality. Like the AHI, we know R&K simply isn't good enough, and we can do better. My next guest claims to have an answer. Dr. Magda Yunus is a distinguished professor emeritus and senior scholar in the Department of Medicine at the University of Manitoba. Odds ratio product, or ORP as it's commonly referred to, has been recently featured in such publications as Reinventing the PSG and Beyond the AHI. But before we bring Dr. Yunus on, a quick primer on ORP.
Any complex electrical activity can be described by a combination of waves through a mathematical process called a Fourier transform. When a Fourier transform is performed in a sample of EEG data, it yields 4 waves of different frequency and different heights. When these 4 waves are added together mathematically, they produce the original piece of EEG. The ORP examines the same EEG data as traditional studies, but summarizes a very detailed analysis into a simple number which measures the quality of sleep along a sleep depth scale. The patient is fully awake at 2.5 and fully asleep at 0. Now, if we add ORP to the EEG, we can see a significant difference in depth of sleep. Line D and E are both traditionally called stage 2, but they range widely in ORP scores, with one being 1.2 and one being 0.4. Line E and F are very similar in terms of ORP, and yet are different stages using the R and K rules. And so the depth of sleep scale provided by the ORP may be a better way of assessing quality of sleep than the traditional rules.
All of this research is great, but how exactly can ORP be used to help diagnose and treat individual patients? Well, it turns out a simple decile-based histogram of ORP during a patient's night can be an instrumental tool in determining how the patient is sleeping, and more importantly, if CPAP can address the issue. Let's listen in.
Now, I just want to show you as a shocker. I just at random picked up 2. As you can see, very little awake, 90% sleep efficiency, little N1, quite a bit of N3 and REM in both of them. So these are both having very normal conventional histogram. And then we did the ORP architecture, and look at the difference. This one can never happen in normal people, because on the left side here, there is very little deep sleep, which would suggest either very little sleep pressure, or there is something else. There is no other explanation for very little deep sleep, except either very low sleep pressure, like, you slept very well before, or that something is preventing the patient from going down into deep sleep, like OSA or PLMs and so on. This patient, which also had normal sleep architecture, look at that. She looks like sleep deprived, and very little down here. This patient really has to be investigated for something that fragments sleep. This patient has to be investigated for something, either primary hypersomnolence or narcolepsy or something like that.
Now we're getting to the fun stuff. Clinically, we know in our heart of hearts, this is what sleep medicine is all about. But how do we scale this? The shift to in-home sleep testing isn't going to go away. And if we can't bring sleep to home, which, let's be honest, that's where sleep happens, well, we may go down the dodo bird path. Again, technology comes to the rescue. EEG is getting smaller and more user-friendly, and at least 3 companies are either offering or developing self-applied in-home PSG systems for the US. Here's an example of a device built for in-home use and available in Canada today. Let's take a look.
You can get a complete picture of your sleep from the comfort of home. Understand your sleep like never before, from the detection of issues to unique insights into your sleep quality. Sleep happens in your brain. Sleep issues can only be understood by directly capturing brain activity. This has only been possible through uncomfortable in-lab studies, until now.
The trend is clear, and COVID only accelerated it as home sleep apnea tests rapidly came to account for 70% of sleep diagnostic studies in the US. If HSATs are our future, you need to look no further than Canada. Outside of Ontario, where HSATs are not supported, home sleep apnea tests account for 80 to 90% of all sleep diagnostic tests. This is why sleep matters. Payers care about outcomes, they care about adherence, and they care about cost. A focus on sleep means PSG should be a requirement for any sleep test. Improved adherence leads to improved reimbursement and improved patient outcomes. Payers, providers, patients. I'm here with Dr. Najib Ayas, who is an associate professor of medicine at the University of British Columbia and the leading expert on obstructive sleep apnea in Canada. So, Dr. Ayas, given where we're at with home sleep apnea testing in Canada, how do you see a shift towards PSG-based diagnosis changing physician reimbursement?
I think that in the future, people are going to be a little bit more reticent coming into the laboratory. And I think that there's a huge opportunity to do polysomnograms in people's homes, what we call these level 2 studies. I think that the extra information that you get from these polysomnograms, especially combined with these new signal processing and machine learning techniques, would more than justify the expense and the cost. I think that if we can integrate these level 2s into regular clinical sleep medicine, I think that would be a huge benefit for the patients. In order to do that, I think that we also need to align some of the reimbursement for these level 2 studies as well. So specifically, because the level 2 study would likely use as much time in order to interpret the studies as a level 1 study, the interpretation fee should be similar. However, I think that you are going to experience substantial cost savings because the technical fee for the level 2 study will be substantially less than a level 1 study. We have done a preliminary economic model to determine what the projected costs are per person, depending on what the first test we use in patients with suspected sleep apnea. Basically, this is the graph that you can see. On the y-axis, you have the cost per person, and on the x-axis, you have the pretest probability of disease. The red line represents doing the level 2 study first. The blue line represents doing a polysomnogram first, and the gray line represents doing the level 3 study first. And basically what you can see is that across all pretest probabilities, doing the level 2 test first is actually the most cost-efficient way to diagnose patients with suspected sleep apnea.
Objective sleep measurement. This is so much bigger than the diagnosis and treatment of sleep apnea. A renewed focus on measuring and managing sleep as an objective outcome gives us the opportunity to dramatically improve health at a population and individual level. My last guest is Dr. Melinda Jackson, who is a sleep psychologist and senior lecturer at Monash University. In your opinion, what do you think is the key to improving sleep in those with OSA?
Moving forward, we really need to take a personalized medicine approach in order to triage patients to the appropriate treatment that best will suit the type of sleep apnea phenotype that they have. CPAP may not be the answer for everyone, and so we need to make sure that we tailor treatments appropriately in order to get people to have the best night's sleep to improve their health and well-being.
I just wonder if there's something else that I could be using other than the CPAP that would help with the snoring, and maybe it wouldn't be quite as bothersome, or it would be easier to use, maybe it doesn't even require to be plugged in.
Everybody's different. There isn't really one right answer, and so you got to kind of keep looking and look for people that can give you some professional advice on what you should try. If a guy can get his sleep patterns down to where you are getting a good night's sleep, 8 hours sleep would be wonderful. That would be super, and I think you could live a longer, healthier life if you could accomplish that.
Thank you for tuning in to this episode of Sleep Disruptors.
Let's put the sleep back into sleep medicine.
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 Let's put the sleep back into sleep medicine.